this gathering from different African countries, and I'm happy because this time we are more interactive, asking a lot of related questions and apply, and I'm hoping to do the best in the future. Before I'm going to highlight the take-home message from all presentations and to summarize and illustrate all activities that were carried out through the last 5 days, I acknowledge and I am appreciating the effort done by Dr. John and Mr. Joseph, because they did their best with humor, and they tolerated all the lectures, detailed lectures, long discussions, and the live translation is so difficult, and so this is why I start with this point. The course started with opening ceremony, and we honor that we have our guest here with us, followed by this certificate, and everyone will have his own certificate. Then, the first presentation was about the magnitude of the problem of renal replacement therapy, including dialysis and transplantation. And we know now that we are speaking about a big problem. Many patients suffered from end-stage kidney disease and suffered to get donor for transplantation, suffered to tolerate dialysis, and a lot of money is exerted, and at the end of the day, these patients are fragile with excess mortality and morbidity. So we should do our best to satisfy them, and we know now from different presentation that we don't target cure, but we target their satisfaction by offering a good care. Then, Professor Samir Saleh enriched this course by his presence in many sessions and shared with us many discussions, and so I congratulate Professor Samir. And his presentation on the first day was touching a very important and crucial issue in dialysis and in health care. You should take care that we are responsible about the duty you do. So targeting safe environment is of maximum priority to be done. At least if we don't have facilities to achieve the highest level of standards, we should seek to do what is available for the best of the care that we can do. So targeting the safety environment, having the policies for everything. If the international policy is difficult to be achieved and done, we can do and we can tailor these policies according to our facilities. And when we tailor these international facilities, we should be following these policies hardly. After that, Professor Nisreen Omar, the Vice Dean of Mansoura Faculty of Medicine, gave us her perspectives from the general aspects of infection control about how to be safe handling, how to avoid spread of infection, and we concentrated on the concept of that we should raise the attention of doctors and even medical students about a simple maneuver, just how to do hand hygiene. Usually neglected, although it's very simple and it saved a lot of life. So we should take care of infection control. This presentation was followed by the same principles of preventive medicine, how to decrease the spread of viral hepatitis, how to maximally use the vaccines available. Sometimes we will say that we don't have these vaccines, at least you should have a list of high priority vaccines. Because if you don't do vaccination for patients, you may be in a critical situation how to do dialysis in isolated area for hepatitis B. So vaccination against hepatitis B is very important and crucial. And we get the lesson that hemodialysis patients are immunocompromised. This is why we don't like vaccines for these patients. And we use inactivated vaccines or toxins or certain antigen. And Professor Samir added that immediately after hepatitis B vaccine, there is no need to check the hepatitis B even in the first months after vaccination. And this course highlighted that we may have occult hepatitis B. So testing for hepatitis B, its antigen, is not enough. And testing for anticore is important, because if you find anticore, this means that this patient has occult hepatitis B. It is not a matter to give the patient injections and saying that the patient is vaccinated. You should be sure that the vaccine works. How to be sure that the vaccine works? Is by measuring anti-hepatitis S antibody titer. It should be above 10 MI unit per liter. If it's less than that, this means that the vaccine is not effective, and you should increase and repeat the dose, increase the dose and repeat the schedule. If at the end of the day the patient doesn't achieve this protective titer, you know that this patient is not vaccinated. Dr. Nasrallah gave us a talk about uremic toxin, and we discussed together the ideas of gut and the kidney and the human body interactions. And the bacteria in the gut may create the uremic toxins that endanger the blood vessels. And he stressed upon endoxyl sulfate. And we discussed together, if we understand the issue, we may encourage the use of complex starch, fibers, and vegetables in the early chronic kidney disease. Because encouraging fibers early in CKD raise a good and friendly bacteria in the gut. Then Dr. Ahmed Hassan gave us idea about the hemodialyzer, because the principles of hemodialysis lie in the dialyzer. Because within the dialyzer, the blood go through the hollow fiber, and they dialysate around the hollow fiber, and then the change between the dialysate and the blood occur. So if we have biocompatible membranes, it's okay. The issue of low flux and high flux is debatable. If you have high flux, it's okay. If you don't have, use low flux maximally. Maximize your dialysis. Because I received one of the questions that we want to treat, but we don't apply good dialysis. We just do dialysis for one session per week or 2 sessions, and that's all. If you do under dialysis, this is the same like you treat diabetes by insulin in general population. You started insulin with plasma glucose 400, and you just give a dose to decrease plasma glucose from 400 to 300. By this way, did you treat diabetes? The answer is no. So offering under dialysis is not a good issue. So we should strive to give the patient the minimum accepted dialysis, and this is through the dialyzer. Dr. Muhammad Abdawad gives us a very interesting and applied algorithm how to use effectively the different strategies of anticoagulation. And we learned that if the patient suffers from bleeding tendency, we may adopt heparin-free dialysis. And this was a very nice presentation. Then my colleague and friend, Professor Donia, gave us a very important topic, which is the dynamics of potassium in dialysis. And he discussed through his presentation elegantly how the hyperkalemia is bad and the hypokalemia is bad too. So we shouldn't keep the patient hyper or hypokalemic. And now we know the best pre-dialysis potassium shouldn't exceed 5 millimole and they shouldn't be less than 4 millimole per liter. And then if you use potassium bath of 2 millimole per liter, it may not be good for all patients. And we stressed upon the use of digoxin. If you don't have except this concentration of potassium dialysate of 2 millimole per liter, please don't. Digoxin is contraindicated in this situation because it may increase the risk of sudden death by arrhythmias. And then he gives us the new advances in the management of serum potassium. And one of the critical points that I want to stress upon, if you have a patient in the emergency coming because of hyperkalemia, potassium of 8 millimole per liter, and you decided to give him the intravenous glucose, insulin, sodium bicarb, etc., these drugs, yes, will decrease serum potassium, but for a couple of hours. So if you give the patient these drugs in the emergency department and you discharge him, this patient may die at home. So if you don't have available machine at the moment, you can give these drugs just to give you a time to prepare the setting for dialysis. This should be put in mind. And if you have the pre-dialysis potassium of 8, and then you measure serum potassium after the dialysis and you find 6, don't discharge the patient because rebound occurs after dialysis. By this way, you may need dialysis after a couple of hours or the next morning. So this is the way how to handle and how to deal with potassium. Then we discussed together with Dr. Samir and Dr. Nagy the ethics in hemodialysis, and we discussed many aspects. And here the discussion about what is the difference between ethics and law. And we know now the cutoff point between ethics and law. And as we said and in the discussion, that we should be ethical in our management and we shouldn't tell the patient any false information. Respecting the patient's autonomy is of utmost importance. And we summarized 8 rights in the autonomy. We should take care of this. Then, in the second day, on Monday, we have with us the Professor Saeed Abdelhadi, the Dean of Mansoura Faculty of Medicine, and Professor Ashraf Fouda. Both of them discussed the one important issue, which is pregnancy. And I tell you that Professor Fouda said to me, this topic may be irrelevant to their interest, but I found explosion of questions to both professors after the end of their presentation. And I found one of the colleagues have experience of dealing with 10 cases of pregnancy with dialysis, and this is a good experience. So this is very important, and you delivered many interesting questions regarding pregnancy, how to take care of the baby, health care system, and the contraceptive methods. But at the end of the day, we get a fine teaching points. We want to allow and to advise against pregnancy. And we get an agreement that the decision of termination of pregnancy is, at the end, is the lady decision. But I should highlight and clarify the risk. So we said that if we are dealing with CKD, we said that serum creatinine less than 1.5 normal blood pressure, absence of proteinuria. If these are the criteria, this is low risk. Except in lupus, because lupus flares with pregnancy. Except with glycoretic reflux, because this reflux increases with pregnancy. So if creatinine is less than 1.5, this is very simple. Less than 1.5, this is a low risk. You allow pregnancy. But if the patient is lupus or glycoretic reflux or suffering from MPGN, these are not simple issues. Then the high risk criteria include creatinine above 3.5, nephrotic range proteinuria, uncontrolled hypertension. In this scenario, I clarify the risk to the lady, saying that this is high risk with bad prognosis for the pregnancy course for the baby, and I should clarify that the lady may lose the residual kidney function. If she insists in pregnancy, this is her right, and I just give her the care. The values between the low risk and high risk is intermediate risk. And my task is to go smart. If you have a lady with no kids, then you tailor your advice and your speech according to the demographics of the lady. Then this presentation regarding pregnancy was followed by the speech of Professor Ashraf, the Vice President of Mansoura University, and he is one of the experts in the field of pediatric nephrology, and he gives us what is the difference between dialysis for children and dialysis for adults. There are some common characteristics between them, and there are some differences, and he illustrated the growth as a difference, because the growth is very interesting topic in children. And then I was surprised by many questions you asked him. You asked about transplantation, what is the criteria of transplanting a child, and we said that we have here our own criteria, because we are not dealing with infants, we deal with adults, but we have a good series of transplantation of children, and we said that 15 kilogram for 5 years, this is sufficient criteria after inspecting the abdomen from the transplant surgeon in the center. Then we discussed together anemia, and we reached the definition, and we stressed upon, before we become rushing in prescribing expensive medications, which is erythropoiesis stimulating agents, we should satisfy the iron stores. So giving erythropoietin to patients with absolute iron deficiency, this is not good. So the treatment of anemia, chronic kidney disease associated anemia, is primarily iron, and iron. But to give iron, we should practice safe medicine. We should check iron stores. And the best strategy to check iron store is the percentage of hypochromic red cells or reticulocyte hemoglobin, which are not available in your country and our country. So how to measure the stores is serum ferritin or transferrin or both. We get that the best is to monitor both serum ferritin and transferrin saturation. If you find serum ferritin less than 100 and transferrin saturation less than 20%, this is a clear indication of iron therapy. If the patient is not yet on dialysis and just CKD, trial of oral iron is mandatory. Because if there is a randomized control study showed that parenteral iron in this situation increases the risk of infection and hospitalization. How to give oral iron is to give sufficient dose for sufficient period. It is not a matter of one tablet or one capsule. We should give the patient 200 milligram elemental iron per day for 8 weeks. If the patient tolerates it, so it's good. If this leads to restoring iron stores is good, but if the patient intolerate or there is no response, these are indications of parenteral iron in these patients. In dialysis, in hemodialysis, parenteral iron therapies are indicated, and we'll discuss the different types. Then, Dr. Gada, the clinician, gave us a good presentation about how to manage diabetes in dialysis. And we discussed together that it is not our target is not to look at just serum glucose or plasma glucose. Our target is primarily to avoid hypoglycemia. And patients with dialysis per se, or end-stage kidney disease, or CKD stage 5 per se, is high risk for hypoglycemia. So we treat diabetes, but we monitor hypoglycemia. And if we treat diabetes intensively in general population, we relax the treatment in dialysis. So A1C, hemoglobin, around 7% is okay. If the patient witnessed hypoglycemia, we may relax even more to the level of 8 or 8.5. Then, Dr. Ala Wafa gave his presentation about the endocrinological perspectives of dialysis, from the hypothalamus to the pituitary, to the adrenal, to gonadal. And they stressed on the erectile dysfunction. They asked a lot of questions about how to deal with this scenario. Then, Professor Wafa al-Bahai, Professor of Psychiatry, gives us a very interesting talk about the communication skills, that it is very crucial. Our duty as doctors is not to prescribe medicine, it is to offer a professional care. And one of the important parameters of professional care is to know how to communicate. And the highest level of communication, how to deliver bad news to the patient. And we get the lesson that, yes, we should tell the patient the bad news, but with compassion, and always give the patient a hope. Because if the patient loses hope, this is a great mistake. Then Professor Wafa gave his presentation about plasmapheresis and the use of apheresis by different strategies and in different diseases and different indications. It was a very interesting topic. Followed by the dialysate sodium in hemodialysis, how to adjust. Professor Nagy introduced to the topic by giving us a talk and a tour in the how to regulate body fluids and sodium. And we get teaching point here about which is the best serum dialysate level. Regarding what is the best level of sodium in dialysate? If we fix dialysate sodium to 140, this may be hazardous to some patients. So the best way to handle dialysate sodium is to look at the pre-dialysis sodium. Suppose that pre-dialysis sodium is 136. So adjusting the dialysate sodium to be the same like serum or plus minus 2 millimole per liter. Why we are stressing about that? If pre-dialysis sodium 130 and you adjust to sodium 140, what will happen? You overload the patient with salt. So the patient will drink a lot of water and coming to your next visit, next dialysis session, overloaded with intradialytic hypotension because you wanted to get rid of all this excess. So the end will be intradialytic hypotension because you will insist to remove excess fluid in short time. So this will lead to intradialytic hypotension. And between the dialysis session, interdialytic hypertension because the patient is overloaded. So this is an important point. And if your patient has very low serum sodium before dialysis, we get the lesson, we shouldn't be rushing in doing aggressive dialysis. The shorter dialysis as we can, and the lowest level of dialysis sodium as we can. And we can repeat the dialysis even twice per day until the sodium rose clearly safely. Yesterday, we started the lectures with the TB in dialysis. And we selected TB in dialysis because previous group asked a lot of questions about tuberculosis. Dr. Tarek Mansoura gives his perspectives, and he illustrated how to modify the treatment, how to monitor, how to deal with active tuberculosis in dialysis, how to be meticulous in picking up latent tuberculosis. And we discussed this issue with Dr. Samir, and Dr. Samir suggests to add here tuberculin test to be done routine for every patient in preparation for transplantation. One of the most important teaching points also is if you give the patient isoniazide, pyridoxine is crucial, and we should modify the drugs according to kidney function. And if you have patient with active tuberculosis, you offer him the treatment, monitoring him, and you can allow transplantation after a year of complete eradication of tuberculosis. And if you allow the transplantation, you continue INH as prophylaxis for 1 year after transplantation. If you have latent patient with latent tuberculosis, and you don't like INH, and you want to use cyclosporin, you should, we would like to use rifampicin. You finish the rifampicin protocol before transplantation, because, as you know, rifampicin has major interactions with immune suppressive drugs. Then, the presentation of Dr. Hussein Sheashaa and Dr. Dua Hamid about the nutritional prescriptions and our goal in the management of patients regarding serum phosphorus in dialysis, and they discuss the nutritional perspectives. And we summarize that even if you do effective dialysis and liquid dialysis, there is positive phosphate balance, because there is limitation for extraction of phosphorus by the dialysis, even if it is effective and adequate. So we should give adequate dialysis, and we should put in mind not to advise against protein, because if you restrict the protein, this will lead to malnutrition and death. So we'll advise protein, but we tailor our advice regarding the inorganic sources of phosphate. And we stated that we should educate our patients against spices, additives, and Coca-Cola, because all these foods and drinks include high level of inorganic phosphate. Inorganic phosphate absorption is approximately 100%, and without any nutritional benefits. So this is our way, is to cut the additives, the processed foods, the inorganic source from Coca-Cola, and allow the patient to eat protein because he is in a state of catabolism. And at the end, we should use phosphate binders. And we discussed in the discussion the different phosphate binder strategies. And we said that if we have limited resources and we have cheaper forms of phosphate binders, use them maximally. This is what we have. And then Professor Abdullah illustrated the logical perspectives of hemodialysis. And he gives us all the radiological figures. He demonstrated yesterday this from the center, and this is a very interesting point. Then Dr. Ayman Maher gave the how to deal with intradialytic hypotension, how to diagnose, and how to manage. And we said that sodium profiling lost its favor currently. So the best way to handle intradialytic hypotension, if we have limited resources, is to avoid excessive ultrafiltration. And you may decrease the temperature of the dialysate by 0.5. That is known as cold dialysate. And then to go to the algorithm that was clarified by my colleague Dr. Ayman Maher. Then Dr. Ahmed Kamal, the secretary of this course, the topic of Dr. Ahmed Kamal was how to conduct palliative care. So I added this topic to this course just to show that hemodialysis is just a machine and blood flow. No, you may have critical situation and you should discuss it from the different aspects. And Dr. Ahmed illustrated all pathways of palliative care, including how to deal with dying patient. And here, this is one of the quotations that I want just to say. Sometimes you are frozen. Sometimes you will just need, and the patient know that there is no hope, because every patient with chronic illness have insight about his illness. So sometimes he wants, just as this quotation said, sometimes people just need someone to listen. No advice, no words, just a shoulder and ear. So giving the patient that you are serious, you are taking care of him, you are listening, using and this is another strategy from the communication skill. Following the spikes protocol that Dr. Ahmed clarified, and I would like to stress upon 2 letters from spikes. S, you should prepare the setting to deal with patient who is dying or has catastrophic comorbidities. So the settings are very important. And the E, empathy. Empathy means that the doctor is a drug and he can solve many problems for the patient and for the family. Today in the morning, Professor Abab Khalid illustrated an updated presentation about the new anti-hepatitis C drugs and how to use them in dialysis. And you asked him, if we don't have money to bring these expensive drugs, how to use? And the answer is to use what you have maximally. Use interferon and ribavirin. In dialysis, we can use ribavirin, but in a very low dose and spaced doses. So 200 milligram every dialysis session. That's the dose of ribavirin. And to monitor hemoglobin. Plus interferon. And the monitoring of interferon is to check CBC. Then the Professor Ayman Rifai gave us a very important presentation about how to deal with catastrophes, because we should raise the attention to the patient dialysis, because the blood is outside the body, and this is by itself is a critical situation. So we should feel this sensation. And the Professor Ayman elegantly illustrated many issues to be done. One of them is very simple, is to educate the nurse and the patient not to cover the fistula, because sometimes the needle escapes from the vein, leading to catastrophic bleeding. And then after the blood fill the space, the patient may die if we don't take care. So if the fistula are uncovered, we can pick up the early catastrophe. And I told you about one case I met in France, in Lyon, and the patient died because of bleeding from the needle that escaped from the vein. And because the pump blood flow is above 300 milliliters per minute. And the patient was aged, was geriatric, 80 years, and didn't withstand the bleeding. And then we have guests from Tanta. Professor Kamal Okasha gave us a very important topic in dialysis, which how to adjust the target body weight or dry body weight. And we get the lesson that target body weight evaluation should be within the context of nutritional status of the patient. So we evaluate the body fluids and nutritional status simultaneously. And Dr. Hana al-Aqda gave us a presentation about pulmonary hypertension hemodialysis, and we know now that the pathophysiology of pulmonary hypertension in dialysis is a complex and not a simple way. The last lecture was to my colleague Dr. Ahmed Al-Wahab, and this is one of the most important topics and the target that I would like to stress upon, which is the target of modern medicine. In the past, medicine was concentrating in doctors, so it was doctor-centeredness. And then the evolution of medicine was toward the disease. But currently, a good doctor treats disease, and the major doctor treats a patient. So patient should be in the focus. And we get the lesson not to deal with the patient as he is the doctor and I just interrogating with him. At the end of the day, I am the professional. I should be professional and following the good communications, good relations with the patient in a professional relation. These are the lectures, but we have the interactive training that all of you are satisfied, and all of them give excellent score for the 3 days of training. So we have training in hemodialysis unit on Monday, and then knowing the intervention and nephrology perspectives led by my colleague Professor Ahmed Dunya, with the help of Dr. Hussein Sheashaa and Dr. Noor and Dr. Mohammed Al-Shaykh. All of these persons, the team, helped you a lot to localize by smart way how to localize, how to introduce the needle by the help of the ultrasound machine. And yesterday, we have a specific workshop about how to avoid dialysis. And it was my pleasure and honor that Professor Ahmed Sheashaa gave us his ideas about how to diagnose and pick up obstructive uropathy, because I want now to stress upon a point. Obstructive uropathy is not just a mechanical issue. After a couple of hours, inflammatory cell attack the kidney. So should be the earlier the intervention, and we should put it in our mind, in our algorithm of management. We should search for potentially recoverable factor, and one of the potentially recoverable factor while we are dealing with our patients is obstruction. And Professor Sheashaa gave us clearly the different modalities that we have to diagnose and you ask them a lot of questions, including how to predict recoverability. So again, and he discriminated between adult and the children. For children, he advised us and recommended not to lose the hope, because we don't know the natural history of obstruction in children. So we always think of recoverability in children. In adult, Professor Sheashaa gave us that we evaluate the GFR and look at the brain demand, and this was very nice presentation. And I followed the Professor Sheashaa regarding and concentrating on the issue how to avoid dialysis. And my presentation was discussing two axes. The first one, we know that chronic kidney disease is progressive by its default. But if we are smart, we decrease just the decline or retard the progression to allow the progression to occur in a low base. This is our target. And I discussed with you the different modalities to be followed for this sake. And then, if the patient deteriorated, kidney function deteriorated, and we have chronic kidney disease stage 5, and we have the facility for transplantation with the available donor, preemptive transplantation for these patients, on-time transplantation without dialysis may be of the best for the patient interest according to the availability. And we discussed a simple sentence about the transplantation. This is some photos from the training and dialysis and the visiting of water treatment at Jihan building. This is my colleague, Professor Donia. This is the video presentation about how to localize the vessels. And this is one of the most important and most respected photo that he himself allows one of the, or more of the attendee to localize the vessels on himself. And he's not only who did this, but Dr. Kamal and Mintana. And Dr. Ahmed al-Bughdadi. So this means that all the team, personnel and staff, faculties are dedicated for your satisfaction. This is Dr. Anur, helps one of the attendees to localize the vessels. And this is regarding our presentations. Here, these are some of photos reflecting how you are very interactive. And for everyone finds his photo, he will be gifted a special issue of American periodicals of nephrology. So this is one gift. A lot of questions. I'm sorry because I don't remember names. I even don't remember my wife's name. So, so I'm happy by all of you. And at the end of this presentation, as I stated in one of my presentations, it is not enough to do your best. You must know what to do, and then do your best. Thank you very much for your attention.
Thank you very much, Professor Sheashaa, for the excellent and comprehensive overview of the updated and evidence-based scientific materials that have been provided during the course. And also thanks to all the speakers who shared with us their vast experience and presented and updated scientific contents covering all the different aspects of hemodialysis science. I think it's now to shift for the closing ceremony. We are waiting for our guests to join us. Just to relax.
لما يشوفوا هم يعملوا ايه الوقت